Ah! Okay.
I gave her stuff. The hell? I gave you stuff. Why would I take something that I gave? So what did I do that I did? I gave you stuff. Now, you want to walk over there? Because you guys want to put me? You want that hour to look for his stuff? Get your phone shit. Don't throw my shit. Don't throw my shit. Don't throw my shit. I'm the one that gave you. And then you want to go. Then you want to go to my shit and take more? So go. Look, the clothes I brought from my house, I brought from my house. Okay? Yeah, that's his sweater. Yeah, she brought so many strips today. The hell? Why am I going to take something out of his house? Take something I can give to somebody. No, I don't take, and he knows I don't. He knows I don't. The shirt you got on, I gave you. Thank you. The shorts you got on, I gave you. Thank you. The socks you got on, I gave you. The fuck? Stop going over track. What? No me interesa, esta vez no moja. Estaba una hija en ahogarlo.
Greetings, everybody on YouTube land. If you have any questions or comments, just put them in there. Put them in the chat. We're live on YouTube, but we're not live on the internet. Oh, let me see here. I gotta put the embed code. Oh boy. And website. Okay. Hello, Mohammed. Can you hear me? Hi, Mohammed. Can you hear me? Can you hear me? Hello, Mohammed. Can you hear me?
Hello, John.
Oh yeah, you can hear me.
Yes, yes. Now I unmute.
Yeah, how you doing? Where are you at, Mohammed?
I'm from Iraq, from Baghdad.
Oh, excellent. Are you in the same room as Samer?
Yes. No, not at the same room.
Oh, you're not? Oh, okay. Good. Yeah, welcome. We're waiting for Samer to come in now.
Thank you.
Where are you from Baghdad?
Yes, I'm from Baghdad.
Oh, okay. Very good. What year, you're a resident or attending?
No, I'm young neurosurgeon. It's just a few months from graduated.
Oh, okay. So you're practicing neurosurgeon now.
Yes.
You're a big boy.
Thank you.
Well, are you in a group or are you alone?
Now I'm alone.
Yeah. Do you practice the same hospital as Samer?
I wish I will practice next few months. I will transfer to the same hospital. But now I'm
Oh,
in
okay.
another hospital.
Okay. A trauma hospital?
In the peripheral hospital now I'm.
Okay.
General hospital, peripheral, not in the center, not in the capital.
Okay. Peripheral? Yeah,
Yes.
Baghdad's pretty big, right? Like 4 million, 5 million people?
I live in Baghdad, but not work in Baghdad. I live in Baghdad now, but I work in the peripheral hospital, not in Baghdad.
Okay. Very good. I'm in Miami. We had a storm. We was having storms this now. We lost the internet a little bit yesterday. It doesn't happen much, but it happens. Let me just chat. Let me just text Samer. I think that's probably him now. Oh, well. Okay. Hello, password. Okay. Okay, that's.
How you doing?
Hey, how you doing, Sammer?
I'm okay.
Yeah, okay. Yeah, it's really storming still in Miami.
Oh, really?
Yeah, it's unusual that the internet goes out, but it went out for a little bit. Um, but I love it. You get tired of the sun. You know, you get so much sun, and it's nice to have rain and clouds.
That's nice.
Good. Okay, so part 4 today, we have a panelist, Mohammed. I don't know, hi, Mohammed. Oh, you probably know Samar, correct? Do you know?
Yes.
Do you know
Is
Mohammed? Do you know Samar, Mohammed?
Yes.
is
Yes.
my
You learn.
colleague?
You teach me too much. Yes.
Oh, it teaches
I
you too
was.
much, huh? You got a
Yeah.
big head. Yeah, Samar likes to teach. That's great. Well, I think we're putting together a good series here that we can show in the future that people can say, oh, watch the neurosurgical operative anatomy series. It's forever there.
Yes, yes,
Okay, we're ready to start.
yes. I'm ready.
Are you ready, Samar?
Uh, a trial for a slideshare? Just a trial?
No. Are you ready? Are you ready? We're about to start when I decide to start. Are you ready?
Okay. Okay, I'm ready.
Okay. Well, let me introduce you first so people can see your face. Okay. Can you get off the screen share for a second? Put yourself back on the camera. Hello, Zolo. You get in.
Yeah, I'm in, sir.
Okay. We're gonna start. Now, one thing, Zolo, if you have a problem with connections because of bandwidth, you might have to turn your camera off because that conserves bandwidth. Do you know what I'm saying? Okay. If you have a problem, maybe you won't. Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, the temporary home of Neurosurgical TV in Homestead, Florida. We have the 4th in a series of Neurosurgical Operative Anatomy with Samar Hose, MD, an Iraq neurosurgeon and a neurosurgical educator. We have a few panelists. Let's introduce them first. Hello, Zolo.
Hello.
Could you please introduce yourself?
All right, I am Zulu Ivan. I am a ETM medical student from the University of Buya.
Welcome. Anytime.
Well,
Okay, Mohammed, can you hear me okay? Can you please introduce yourself?
Yes. I'm
Go ahead.
Mohammed. I'm young neurosurgeon. I'm work in Iraq. I'm colleague of Dr. Samar.
Okay, welcome. Okay, Samar, it's all yours. And welcome.
okay. So thank you, John, and welcome to the panelists, Zolo and Mohammed. And Today lecture is I'm Samer Hose from Iraq, and today lecture is the fourth of our series, and I will start the slide share now. Just tell me if it's okay. Is it big enough?
Did you want to make the screen bigger, Sammer? It's not the entire screen yet.
Okay.
Okay.
Is it better now?
Yeah, perfect, okay.
Okay. So our lecture today is the upside down operative anatomy is a concept to be discussed, and it's the fourth of series of 10 about the neurosurgical operative anatomy presented here in the neurosurgical TV. And sorry for the delay of the time of this lecture. And this is maybe not a new concept, but we think that this is an important aspect of the neurosurgical operative anatomy that should be covered and should be understood in a good way. So as usual, we start our lecture with this slide. We are nothing without our teachers, and we are shamefully inferior to them if we do not advance beyond them. And our topic, the upside down operative anatomy, in general, it's what we mean by the upside down operative anatomy, or why there is an upside down operative anatomy. The cause is not all the surgical approaches or the cranial approaches, but some approaches that require putting the patient in such position that in supine position, and the surgeon came from the top of the patient. So the anatomy will be inverted, or the anatomy will be an upside down. And we will give some example and what's the importance of knowing that and how to include that within your study. So this is just an example of, this is the usual illustration put in the books about how to do subfrontal approach or subfrontal craniotomy or something like that. And this is the real view, and this is the real anatomy. The surgeon will look within the surgery from another angle. So while studying neuroanatomy, you should keep this in your mind, and we will give more example about that. This is the usual illustration of how to open the skull and craniotomy, like terional, but this is the actual position of the skull and the brain within the skull. This is just an introduction slides, and it's just to put an idea in your mind that the brain is like this when you are approaching the patient from subfrontal approach or maybe from terional approach. It will be just inverted and even oblique. Actually, it's not only an upside down, but also oblique. This is an example of how the neuroanatomy, the valuable neuroanatomy book, show the anatomy of the area around the chiasm with the blood supply. And this is the real intraoperative picture, or let's say this is the real intraoperative view, because we will, in the intraoperative view on the right side, we will look and we will see the chiasm, and the skull is the top of the view and the brain is the lower part of the view, while it's the opposite in the usual neuroanatomy book. That's has a critical importance and should be always kept in mind that when I study anatomy, I should flip it upside down when I will operate through like terional approach, which is the most common approach used in neurosurgery. Another example, it's actually it's not only the upside down, but it's also an oblique, because This is the usual view of terminal approach, like dissecting any lesion around cellular or supracellular lesion or paracellular lesion, or like doing aneurysm surgeries. These are one of the most common views, and it represents an upside down anatomy with a little oblique view. One of the best books that demonstrate this concept that we are discussing in this lecture, the upside down operative anatomy, is the Atlas of Neurosurgical Anatomy from John Fox. It's maybe not very well known books because it's not a new book, but this book have a special idea that it's the Atlas of Neurosurgical Anatomy from Terional perspective. And this is very nice idea because Terional approach is the most common approach in neurosurgery. And in this book, he illustrates what we can see during this approach, like studying the anatomy or dealing with the anatomy through the approach that you will use as a surgeon. And in the preface of the book, he states that the Torriano approach to certain intracranial problem is being used with increasing frequency, and the photograph presented here, which means in the book, give us the terional or frontoparietal perspective, a perspective that's turned upside down and oblique in comparison with other standard anatomical illustrations. Yes, this is the view as seen by the neurosurgeon. And actually, I search a lot of books. This is maybe one or two books in neurosurgery take important or focus on this concept, which is quite important, that the neurosurgeon views of anatomy are different from the anatomical illustration, the usual anatomical illustration. And in the same book, John Fox states that the surgeon, at least in the Torriano approach illustrated in this atlas, must view the patient anatomy from an oblique and upside down orientation with respect to the patient. That's the idea. And this is an example. This is the usual position for Torriano. And in this view, we are looking to the patient and we are standing just on the top, just on the opposite side, and we are looking to the head of patient, trying to prepare the skin before doing the surgery. So this is our view as a surgeon. And in the same book, he put a comparison. Sorry, he put a comparison in the right side. Yes, in this image, he illustrates an opening in the skull as a Torriano approach and showing the cilia, and he put a plastic, red plastic, as a symbol for basilar artery. So this is the usual site of basilar artery if you are open the skull in this way, like a Torriano approach. But in the operative field, in the real operative field, the position will be like this, or the view will be like this. Because the patient is upside down, so the Torriano approach will show the tip of basilar pointing down instead of pointing up in the anatomical illustration. I think this or these two images or comparative images are the most clear illustration for this concept about why they said it's upside down. It's all the same. No, it's not the same. While you are dealing with a deep, especially while you are dealing with a deep structure within the surgery. So another example, I think this may be more helpful to the beginner, that in this video, I get it from the upsurgeon application, the simulation. He illustrates the surgical steps, and actually I want to see or to demonstrate some steps. So let's say it's an anterior communicating artery aneurysm, and this app are used for planning and doing surgery virtually. I think it's very interesting. And let's say it's ACOM, so the lesion anterior communicating artery, and this is the lesion site within the skull. And if we are doing a radiology, that will be the position of lesion. And the most important for me is when you put a plan, what's the most appropriate approach? Like in this one, this is the right trional. You open the right trional. This is the vascular anatomy. Then the next step, well, you should flip the skull because the patient will be flipped. Yes, just like this. This is the best illustration where the carotid will came from the roof to the floor direction with a little inclination. This is the concept of our lecture, the upside down operative anatomy. Please spend a good time with it. Imagine how will be the anatomy when it's inverted. And this is why, this is the cause, because we put the patient in certain position that change the anatomy for you. That the surgical step demonstrated in this video. I think it's very informative for young generation about the usual surgical steps, but it's not our topic for discussion. I will skip the other steps, although it's very nice video. Maybe next slide. Yes, this is a continuation of the same approach, like doing surgery for intercommunicating. Yes, the surgeon will be standing here just above the patient or on the top of the bed, and now like opening the sylvian fissure, changing the direction of microscope, as illustrated in this video. Here the middle cerebral artery, the carotid artery, the A1 anterior cerebral artery, the optic chiasm, and this is the inverted anatomy, where here the optic chiasm is above the A1, while in anatomy the A1 is above the optic chiasm. Here the ACOM is below the A1, while in anatomy it's above. That's the idea, and it's very nice illustration. Actually, it's terional perspective, Transylvian approach, and this is how we advise to study anatomy. Like put the anatomy in your like uh, like the real operative field, because you will face it in a day-to-day life. Next slide. I think we give this illustration in the first lecture when we give the general introduction about the topics, but I think it's worth to be repeated again, to be included within this lecture about the upside down operative anatomy, and it will be the last example. The first example is the book of John Fox, the second is the operative video and operative video for the steps, and the third one is this for demonstration of anatomy. Maybe this is, I can make it a small quiz about what's the artery in the middle. Yes, these are two vertebral arteries joining to form basilar artery, and this one is the internal carotid artery. Internal carotid artery bifurcation into middle cerebral and anterior cerebral. M1, A1, M2 is the insular, M3 is the opercular, and M4 is the cortical branches. And the A1, A2, and the intercommunicating is between them. On the other side, M1, M2, M3, and M4. So in this illustration, this is a CT angio for a patient with subarachnoid hemorrhage, and the CT angio show the middle cerebral artery bifurcation aneurysm. First of all, it's a trifurcation, not bifurcation, or maybe some claim that it's a bifurcation, but actually it's a trifurcation, not a bifurcation. And the second one is it's an M1 aneurysm, not M1, M2. It's in the end part of first part of middle cerebral artery. So this is middle cerebral artery aneurysm, other bifurcation. This is the usual view, anatomical view, and if you notice that, what's this? This is the carotid artery emerging from the skull. I hope the pointer is clear here. Emerging from the skull, carotid bifurcation to the right, anterior cerebral, to the medial, anterior cerebral, to the lateral is the middle cerebral artery, and at the end of this horizontal part, there is the aneurysm with the bifurcation or trifurcation. In the middle part of this M1 segment, there is a small branches just above and below, and these are perforator. Maybe the lower one is the anterior temporal branch or early temporal branch. And when you consider the size according to the centimeter put in the same image, so it's like there is 1 centimeter from the carotid bifurcation to this perforator, and another 1 centimeter till you reach the aneurysm. This is very important. This is how to study the operative anatomy for the same patient, specific for the patient, depending on the radiology. And when you flip it, this is an inverted view. This is the surgeon view of the same angiography. There is a carotid bifurcation, middle cerebral artery, one branch above, two branch below. Actually, it's one branch inferior and two branch superior, but this is not an anatomical position. This is in an operative position. So one branch will appear above the aneurysm, two branch will appear below the aneurysm, and that's the most important for a surgeon. As an example, with the same example, as we said, there is a superior and inferior small branches, and these are emerging from the middle cerebral artery. More dissection, these are the branches, superior and inferior. After getting dissection distal to the branches, you get close to the neck with temporary clip, then permanent clip to the middle cerebral artery bifurcation aneurysm. And at this moment, you must check for the branches, the three branches that emerge from the middle cerebral artery. This branch, which is located usually in the operative view, will be located above the aneurysm, and there is two branches below the aneurysm. And in the operative comparison for the same case, this is the superior branch above the aneurysm, and the aneurysm is here, just below the bipolar. And this is the two inferior branches. This one and this one, this one and this one. These are the two inferior branches. Sorry, but I said inferior based on the operative view. In reality, they are the superior or the frontal branches. And these are very important to preserve during the surgery, and this is the most important to get a good outcome. So always use a surgeon view, making the anatomy different and making the anatomy flipped upside down. And that's our message, that please think of the operative anatomy, think of the inverted anatomy. And as always, take home message. The first two messages are fixed, that I learn anatomy not from books but from the sections, not from trends of philosopher, but from the fabric of nature. This is the talk of William Harvey and Hunter's equation: surgery equals to anatomy plus hemostasis. Always you need a guidance, or always you need a mentor actually, and the best class or the best course to learn anatomy is the real surgery. And today we add that you should know the neuroanatomy in the anatomical position, and also in the upside down position, or in the inverted position, or in the real operative position. That's our message. Next Sunday we'll meet, I hope we'll meet about the fifth lecture on the fourth principle about physioanatomical principle. I think it will be an interesting lecture, and thank you.
Great, Samer. Thank you very much for another excellent presentation of part 4 of the series. And let me say again that this series will be available forever on YouTube. The series of Neurosurgical, you can reference it at your convenience. But let me just ask the panel if they have anything to say. Mohammed or Zolo, any remarks for Samer or comments? Weil, I'm sorry, we have a new addition. Weil, could you introduce yourself to Samer, please? Can you hear me okay? Okay, go ahead.
Okay, I am Dr. Wael. I am a neurosurgeon from Sudan. Hi there, Doctor.
Welcome, Wael. Welcome, Dr.
Great. Sudan's connecting. That's great. That's great. Okay. Any comments at all, Mohammed, for one of your old mentors?
It's amazing lecture. I know this case, these cases that's presented in this lecture. Amazing lecture. Thank you, Dr. Samar.
Very good. Samar, you want to show your book that you wrote, the neurosurgical, it was vascular?
And where to show? Sorry?
Well, I don't know. Just show the website, Amazon. Show the Amazon. Samar's written a book recently, right? It was just published like 6 months ago or a year ago.
Yes, it's about a year ago. I think there is a new book will be produced within the next few months. It will be more interesting.
It's no big deal. I just thought I'd do that.
Yes.
Okay, Samar, thank you very much, and we look forward to next week. And to the viewers, these talks are archived on the website Neurosurgical TV, and also on Facebook. There's a link for the previous 3 presentations. So we're going to go off the air now. Thanks everybody for coming. Stick around. I'm just going to stop recording. Thank you.
Thank you.
Okay.
Thank you.
Okay, good. Okay, it went well. It's all recorded forever for posterity.
All right.
Well, okay. I'm glad to see. I know that you were having problems in Sudan getting internet for a while. Is it okay now?
No, it's not. I'm here in Saudi Arabia, not in Sudan.
Oh, I'm sorry.
unfortunately.
I'm sorry. I thought you were. Yeah, I know that we were having trouble connecting there for a
Yeah,
little
yeah.
bit.
Still
But,
hope that this will be great.
Yeah, welcome, While the other 3 talks are, I don't know, they're on the link is on Facebook. You can access them. So, okay, gentlemen, any talks that you want to televise about anything? And Samar, you're always available. I mean, this series is plenty. I mean, you're a busy guy. You're a busy guy. Just put this in once a week.
I complete surgery today. It's very interesting for the first time. I think maybe if it's not the first time, for the second time in the Iraq history to do a surgery for Moyamoya disease. It's a rare disease.
Oh, yeah.
Like the direct or indirect vascular anastomosis, and we did an indirect anastomosis, and we just complete the surgery before 30 minutes from now.
Oh, really? I just came into the studio, right, from the OR.
Yes, yes.
That's great.
Hello. John.
Go ahead, Zolo. Go ahead.
Yeah, I just wanted to contribute. Just wanted to say that it's really amazing to be able to like know that as a student, it's not just reading or reading anatomy as in the anatomical position of the patient, but you also have to be able to put yourself in a surgical, like in a situation where the patient is going to the position of the patient is going to be adjusted. So I think the lecture was really a great idea, giving us to know that in the theater you're not always going to have your patient in your anatomical position, so you should be able to manage anatomy in your brain. So I think it was really a great idea to have this video. Thank you very much. Thank you for the presentation. Thank you to the presenter.
Thank you, Zola. Thank you, Zola.
Okay, thank you, gentlemen. Go ahead,
That's the real
I'm sorry.
idea of the lecture. I'm talking to Zolo that I appreciate his comment, and this is the idea that if you are starting reading anatomy or as a resident or as a medical student, please start it in this way. This is a more mature way, a surgeon way of reading anatomy. It's totally different. That's the idea of the whole series, that to show you different concepts that you will focus on, and after getting these ideas in mind, I think the reading in your anatomy, it will be totally different. Like you are reading anatomy and imagine the surgery at the same time.
All right. Thank you very much. Thank you.
You're welcome. You're welcome.
Neuroanatomy is like breathing to a neurosurgeon. It's just part of your existence. Hey, thanks a lot, Samar, and thanks all you guys for coming.
Thank you, John.
Bye-bye. Have a good day, guys.
Bye-bye.
Oh, we
Thank
have,
you
a,
all.
we have a Chinese neurosurgeon here, Sam. I don't know if you want to say hi to him. He's a little late, but we could admonish him. But yeah, he's a Chinese neurosurgeon. I believe he's in Shanghai. Hold on, Yonghong. I think you may have met him. I'd like you to meet him to meet all you guys. Hello, Yonghong. Let me unmute you there. I want you to meet everybody. Okay, hold on. Can you hear me okay, Yonghong?
Yeah.
Okay, how you doing?
Okay.
There you go.
Okay.
Hello. I want you to,
Our lecture is over.
yeah, you're a little late. A little late. Sammer finished, but it's all taped. It's okay. It's all taped. I'll send you the recording, okay?
Okay.
Okay, I want you to meet all these people here, and first meet Sammer. Sammer Hose, he's an educator from Iraq, a neurosurgery educator. This is Yonghong Wang. He's from Shanghai, correct? Are you in Shanghai, Yonghong?
I'm from Taiyuan.
Oh, okay. Yeah, he participates a lot in this, and we're going to be seeing. Are you going to be in Beijing in September?
Yes.
Oh, good. We'll meet him there because we're going to the neuro.
Welcome to Beijing. I will be there at
Yeah.
September.
Oh, great.
Yeah. Yes.
Great. I'm looking forward to it.
We have a special session for 9th September.
Oh, you have to present? Are you going to present? Are you going to? That's the WFNS conference in Beijing.
It's not me session.
Oh, okay.
Yeah.
Okay, it's a big conference, right?
Yeah, big conference. Yes. Welcome everyone to Beijing.
All right. That'll be great. Well, hopefully we'll have a nice booth there, Neurosurgical TV. I hope, or maybe small letters.
Okay.
But we'll have a booth there and be interacting with neurosurgeons around the world, hopefully.
Yes.
I never been to that conference. I've never been to Beijing, but it's easier. I don't know, Sammer, how much, have you been to China, Sammer?
First of all, welcome, Dr. Wang. And actually, I have an abstract accepted for oral presentation in Beijing conference of the WFNS also. So mostly I will attend it.
Oh, good. You're going to go?
Yes. I have a talk
Oh, you're going to present?
Yes.
Oh, great. You're going to present a paper?
Yes.
Oh, excellent. You know, I think they have some. Yeah, they have someone else televising it because we're not big enough because it's a big conference.
Yes, true.
But we may televise some of Ipes talks because he's giving I guess Yonghong, he has a block of time for cisternostomy because they have like 7 different rooms at the same time. Big conference.
Yeah.
And Ipe is, I think, in one of those rooms presenting.
So, I think we will meet together. I hope.
Yeah, that'll be great. You know, you can get a visa pretty easily because it's a conference visa. You know that, right, Sammer?
Yes.
Yeah. You know, I didn't know that. I thought you had to get a visa. Is sometimes difficult. It takes a while. But here's someone else that came a little late. I don't know. Yeah, it gets confusing with different time zones and changes, but that's part of the game with Zoom.
Yes. Maybe today lecture is too short. I keep it short because I don't want to repeat the same ideas, just a few examples, and that's it.
No, that's a good idea. That's a good idea, Sammer. That's very good. So, hey, you guys stay here. I've got to go, but you guys can stay here. I'll leave the room open, okay? Okay, Young Hung?
Yeah.
Oh, I'm gonna go. Okay.
Okay.
Well, maybe I better close it. Okay, gentlemen, I'm gonna stop the meeting now, okay? Young Hung, we'll talk to you soon out in Sammer, okay?
Okay.
Okay, bye-bye.
Bye bye. Bye bye.